soon, we might have screening with very short sequence MRIs, 5-minute scans, which will cost less than £100, and will involve no injections. You don't need a doctor present, and so we can kind of do them anywhere. And obviously we need the evidence before that, but very important in rolling out that, as in all screening programs, will be quality control.
Well, hello again. My name is Mike Bewick, and welcome to the Innovating Healthcare session, this time on prostate cancer. I'm very pleased to welcome our panel today, Dr. Jayne Spink, Professor Mark Emberton, and Christopher King. So I'm going to ask them to individually introduce themselves and what their roles are, and then we're going to come and discuss in detail, I hope, some of the advances in the treatment and screening of prostate cancer, and some of the innovations that have being in place that are making this a much more accessible treatment area for patients. So can I start with you, Jayne, perhaps?
I'm Jayne Spink. I'm the Translational Research Director for Prostate Cancer Research, which is a research charity that's been funding academic research for around the last 30 years. And my role is to find ways to better support and promote translational and clinical research for prostate cancer.
Thank you very much, Jayne. And we move on to Professor Emberton, please, Mark.
Yeah, hi. So I'm a urologist working in prostate cancer at UCLH, over 20 years now, looking after patients with that condition or men at risk. I'm also a professor of interventional oncology, specializing in prostate cancer, and dean of the Faculty of Medical Sciences at UCL.
Thank you very much. And finally, Christopher King.
Hi, I'm Chris King. I'm a senior director at the Real World Solutions team for IQVIA, and I have a keen focus in the oncology area and focus in on integrating our therapy area specialization into our real world solutions.
Thank you all very much for those introductions. I'm a man of a certain age with a keen interest in what you're all going to say. I've got a keen interest also because my father died of prostate cancer about 9 years ago now, and he lived with it for, I think, 23 years. So I think I've seen that sort of aging end of prostate cancer, but I know you're as concerned about other age groups as well. So perhaps, if, Mark, I could start with you as to what's the impact of the disease on society? It's epidemiology, if you like. It's the way it presents itself and what the disease burden is.
Yeah, well, I think before I answer your question, I think we can say there's a lot to be proud of. All right, many of the innovations have been UK-led. We've transformed the diagnostic pathway for men with prostate cancer. That's now has global reach. We were the first, and indeed continue to innovate, in metastatic disease. That's the disease that has spread beyond the prostate and is incurable by the discovery and administration of abiraterone as the first intervention that actually, prolonged life. Until then, and probably in your father's day, very sad to hear about that, he was given interventions that would control quality of life but wouldn't prolong life. That's transformed now. So I think that really good news. UK's led the world. I think in implementation and in terms of equity of access around the country to high quality diagnostics and the full range of treatment options available, there's still much to be desired. Maybe we can talk about that in the future. The thing about prostate cancer, to catch it early, we really need to identify it in a preclinical phase, so before men complain of anything. And that's why there's been a huge amount of interest in screening. Screening kind of hasn't worked so far, but I think the general view is that we've had the wrong tools. So we've used PSA and biopsy, and with imaging and various other interventions, we think we're coming to a place where we can identify clinically important disease in the asymptomatic man. So I think, and again, we can talk a bit more about that as we go on.
Yeah, and it's interesting. I was hearing on the radio this morning, Sir John Bell back on the radio, the 5 million screening program we're talking about, and I presume you'll be inputting into that. And if I could come perhaps to Jayne now, in your charitable organisation, obviously you're doing a lot of research, that translational research. What are you finding are the sort of knowledge of the population now, if you like, about what's going on, and would they know when to come forward and seek help, or where to get appropriate screening?
I think that there is a significant problem in terms of awareness of risk factors for developing prostate cancer, and also in relation to potential symptoms of prostate cancer. And therefore, it is most likely that men are not coming forward for PSA testing in all cases. So I think that there's a lot to be gained by increasing public awareness of prostate cancer, the risks and the symptoms. And if we think a little bit about the scale of that, we're seeing around 57,000 new diagnoses per year. We're seeing an increase in hospital administrations that are related to prostate cancer. We know that around 1 in 6 men will be diagnosed at some point in their lifetime, and that there are more than 400,000 people living with or after the disease in the UK. So that gives you a feel of the scale. And also just really noting that during COVID and during the period of the pandemic, we do know that not as many men will have come forward for PSA testing, whether or not they're symptomatic. And therefore, there is likely to be a backlog of individuals who could have benefited from screening earlier.
We'll come back to screening in a minute, but Christopher, just to bring you in now, you work for a very large company that sorts out a lot of data to help, particularly with clinical trials. And I wondered what your view was on where we're going with this disease, and how much you're picking it up, and are we getting people involved in clinical trials, which is becoming a bit of a problem in the UK, isn't it?
Indeed, and certainly from my side, I would advocate for the importance of continuing to collect clinical data, as it's incredibly relevant in terms of generating new and innovative therapies for patients. But I think, oftentimes I believe that the real world data is what is incredibly vital in terms of being able to increase the awareness among patients, and discovering patients that are potentially asymptomatic for prostate cancer. I think a lot of the research seems to suggest that there are age bands that we need to be focusing in on. Depending on the countries and the research that you reference, it's somewhere between 45 and 55 that you want to be starting those screening programs. There are a number of additional risk factors that we would want to consider as well. So ethnicity being one. I believe patients with African descent tend to have a higher risk. You mentioned your own familial prostate cancer, and certainly that's been identified as a significant increase in terms of risk for patients. So certainly, I think utilization of real world data to support identification of patients is a viable area now. We're seeing innovation in terms of AI, ML, and in terms of diagnosis to really try to improve on identification of patients.
Okay, and Mark, I've come to sort of the next area I wanted to concentrate on now, which was obviously policymakers. The NHS has moved to another different type of structure, which has sort of been long in the making since the new act came in earlier this year, and we now have integrated care systems and integrated care boards. What is the sort of thing that policymakers need to keep into consideration when they're looking at picking up this disease early and trying to make inroads and getting upstream?
This is a very difficult area, because you can introduce healthcare technologies either too early or too late. It's very hard to get it absolutely right. I mean, I'm on the too late side. We developed MRI. We were using it for 12, maybe 15 years before, and there were 9 randomized trials, all of which were positive. Our own, which is the definitive trial in the New England Journal of Medicine, was overwhelmingly positive. And it wasn't until 2019 that NICE decreed that MRI should be done for all men prior to biopsy. and we were shaking our heads, but we've been doing this for a decade and a half. And it was very frustrating because a lot of policymakers can sit behind the nice guidance and wait until it happens. There was a huge delay in this. This is a cost-effective intervention. There's almost no downside to it, almost no downside to it. And had it been implemented earlier, more men could have benefited. And so, but I know it's difficult. I know NICE have a lot to do. And now we're seeing the same with some of the new therapies that treat people in a less invasive way as an outpatient and avoid the risk of incontinence and sexual dysfunction. Overwhelmingly positive. Men fight to get on single-arm studies when we offer these. And again, none have been approved yet. They're still regarded as experimental, despite them being in use and offered in NHS hospitals. A huge amount of evidence available, admittedly not in large-scale randomized studies, and there are good reasons why that's the case. But again, it's just denying the process of technology diffusion throughout the rest of the country. So the treatments that I do, these focal treatments that are minimally invasive, are not available in the north of England. They're not available in Scotland. They're not available in Wales. They're not available in the southwest. There's huge inequity in terms of provision and access because they've been very kind of metrocentric. Plenty of people in London offering them, people flying from all over the world to have these treatments done, but we're not equitable in terms of our provision for all English or indeed Scottish or Welsh men.
I remember many years ago listening to a former colleague of yours in London, Mr. Christmas. That's why
Yes.
I remember the name. It's an unbelievably easy name to remember, and I always figured I'd go to him for my prostate cancer when it occurred, because of the moving towards that minimally invasive.
Yeah. He sadly died, very young, but he was a superb, excellent surgeon. Yeah, I learned a lot from him.
Yeah, at that time. So if I could just come back to you, Jayne, obviously your patients who've been in trials and worked with your cancer charity probably give you feedback on all of this. Do you get that same message that we have sort of still a regional dichotomy here of available treatments, or even more than the dichotomy, I guess?
Just reverting to the diagnostic point and to reinforce the point that Mark made about London centricity. Last month, the 2-year pilot study, the RAPID study for prostate diagnosis, was published. And RAPID stands for Rapid Access to Prostate Imaging and Diagnosis. And that was piloted in 3 West London trusts. And it's a one-stop model where men can have their MP MRI assessment and, if necessary, a biopsy all in the same day. And speaking to the point on what ICSs do, well, I think that diagnostic capacity needs to be addressed, and it would be really great to see the rapid diagnostic pathway rolled out across England and indeed across the UK. So making that available to all men whose risk profile or symptoms warrant a referral. And secondly, on this point of the personal impact of prostate cancer, it impacts on the daily lives of men and their partners in all sorts of ways, both prostate cancer itself and side effects of the treatment. And it's really essential that people diagnosed with prostate cancer have information, for example, in relation to treatment choice, symptoms, and side effect control, and that they can benefit from practical support and emotional support that very often is offered through national and local voluntary organisations. So I think the second thing that the integrated care partnership should be looking at is to collaborate with system partners with a real emphasis on the voluntary sector, both in terms of raising awareness and sparking awareness of potentially the need to visit a GP or to seek screening or diagnosis, but also then in relation to dispelling some of the misconceptions about prostate cancer and encourage those initial conversations. And in terms of access to clinical trials, we definitely see that reflected. We see a huge appetite for participation in clinical trials, but we also see that that's very geographically specific as to whether you're able to enter into a clinical trial, whether you hear about clinical trials, and the whole process, I think, if you're an individual seeking to participate in a clinical trial, a lot of the databases that exist are not very accessible to patients and to laypersons in terms of understanding A, clinical trials, and B, what trials are available and might be relevant to the individual.
Can I just ask you how you think we could improve that then? And maybe I'll move on to Christopher after you, just to reinforce that. Are there any specific quick wins, if you like, to get people more involved?
I think that making better use of real-world data to generate real-world evidence is one thing. And I think there's also a lot to be gained from improving the way that we might systematically communicate with and collect patient outcomes and experience measures from people affected by prostate cancer. And we've recently undertaken a number of focus groups for men affected by prostate cancer. And one of the things that they have really been supportive of is the need for a registry that would allow people with prostate cancer to be data donors, to consent not only to the use of their data, but also to recontact in the event that there is a clinical trial that is looking to recruit and that might be appropriate to them as an individual. So I think the appetite is there in the patient community. And I think part of the key lies in better use of real-world data.
Yeah, I think if we have in every contract, in every hospital, a commitment to introducing people to that, to research as part of their treatment program, it would be a great help. And Christopher, we recently did a webinar on data as part of the chamber look at how the biohealth sciences are progressing and how we can use innovation and learning from COVID, etc. And we were privileged to have Professor Van Goldacre speaking to us about the trusted research environments and the use of that data. Is that sort of thing making a difference now, so that patients are not inundated with multiple people asking them permission, etc., to use their data?
Indeed, I think that, as we talk about innovation, there is innovation on the side of data collection, and e-consenting is now one of those elements. Has become much better understood, much better communicated with patients, and I think with that, in previous clinical trials, oftentimes the data was only consented for a very specific, narrow usage, and now we're seeing much more relevant consents to allow for patients to allow their data to be used more broadly in a whole host of research questions that might become relevant after that initial study. I think one of the other elements that I think we've touched on here is just around how do we ensure that we engage the relevant experts in terms of formulating the strategy for prostate cancer patients and improving their outcomes. I mean, certainly we've seen difficulties in other countries where maybe the wrong experts had been advised, or individuals not using the data appropriately. So I think, ensuring that you've created the right team, that you have treating urologists, you do have charities involved in the conversation, you do have patient advocacy groups or patients specifically that are involved in those conversations, you can really start to create clinical trials or more broadly research that really does fit with the challenges of the urologists themselves, the patients as they're embarking on their diagnostic or treatment journeys. And we feel like we're at an age now where we should be able to do those kinds of research that are really tailored and incorporating the voice of all these experts into the research.
Thank you very much. And earlier, Mark, you indicated some of the problems with diagnostics and perhaps that there are difficulties in getting to a diagnosis. Is there hope that that's improving nationwide, or are we still got pockets where actually getting that urgent MRI is going to take a little bit longer than we thought? And I suppose the pandemic's had an effect. We have to recognize.
Yeah. I think UK was the world leader actually in this. We were the quickest to make MRI standard of care. USA were years behind. I think other countries are catching up and may have eclipsed us now, not on just availability, not just on backlog and waiting lists, but actually the quality. It's the quality of the imaging that varies around the country, and it's very tragic when we see a patient who comes from elsewhere and we look at the imaging and it's just not adequate to make a diagnosis, and then we have to repeat it. But of course you can't repeat it because the patient's just had a biopsy and that affects the quality of the imaging anyway. So the patient's left waiting. It's very, very frustrating. So they've got a cancer diagnosis, but there's not much we can do. So and we're trying to do a lot of work with implementation science, quality control, quality assurance. We've developed quality risk scores for imaging, which are slowly being implemented, but there's still a big discrepancy in terms of what's available. But we, hopefully it will improve, and the tools to do that, exist and can be used. But the implementation science is something that perhaps we ignore a little bit. We love coming up with something new. We publish it. Everybody shouts, "Oh my gosh, this is wonderful!" And then actually executing it and getting it into practice to a high level in an equitable manner, with great quality control is more of a kind of industrialization skill that perhaps doctors and others don't possess as well. And I think that's probably an area that we need to concentrate on. Soon we might have screening with very short sequence MRIs, 5-minute scans, which will cost less than £100, and will involve no injections. You don't need a doctor present. And so we can kind of do them anywhere. And obviously we need the evidence before that. But very important in rolling out that, as in all screening programs, will be quality control.
That's very interesting. And I think that, as the NHS vies with numerous priorities and numerous, even just within oncology, where do we make the case for this being at the top of the list for investment? And I guess that's my sort of final area of questioning to you all. Why is this a priority for the NHS? And why is it a priority for society, I guess? I may as well start with you, Mark, and then I'll move on.
Yeah, we have to prove that it's cost effective. We have to prove that it's a very good use of taxpayers' money, that we reduce premature death sufficiently to make the initial investment 10 years earlier or 15 years earlier worthwhile. We're set to do that. It looks as though the UK will run the world's biggest prostate cancer screening study. The grant hasn't been accepted yet. It's in the process of being written. All the agencies are at least talking to each other. So I think if we have this conversation another 2 years, we might be able to say, yes, we're in the process of collecting the data.
Okay. What's your view on that, Jayne? How are we going to make sure that it gets prioritised?
I think to look at it from a very sort of simple, straightforward angle, a significant proportion of the population is susceptible to prostate cancer. It's a public health issue. The cost to the NHS, and not least the human costs of the disease, escalate dramatically if you have advanced disease. And at the same time, early diagnosis and effective, less burdensome treatments ultimately is going to improve quality of life and prove cost effective for the NHS, we hope. And I think, to Mark's earlier point, that what's really essential is to ensure rapid uptake of proven innovations so that the infrastructure is there, the funding models are there, the skills are there for the delivery of new tests and treatments and models of care.
Thank you. And Christopher, just to look at it from a slightly different angle, you mentioned before about the other age groups we should be looking at, down to the 40s as well as sort of my age group in my 60s sort of thing. In terms of the cost effectiveness of that, we never sort of think in the wider societal, and I'm very keen on the concept of presenteeism and actually productivity, and the quicker we get people back to work and enjoying their lives fully rather than accepting they're going to be ill for many, many years. I guess you'll see that in your statistics, that it's the working population that we're looking at as well these days.
I'm certainly, I would certainly advocate for supporting all patients with prostate cancer, and well, all cancers in general, and ensuring that we are providing the absolute best care that we can, irrespective of age group, irrespective of the geography in which they live in. And yeah, absolutely. I think, we've spoken about the point of ensuring that they get the right clinical care, but it is also about the quality of life of patients. And we do have the ability to look at the data and look at subpopulations and see how do we actually right size the care for those patients with the data that we have, and ensure that we get the best outcome for them, both clinically as well as it relates to their quality of life.
So to summarize, this is a very common problem. It's an increasing problem as we get an aging population. UK PLC has been a success story and is leading the world in both innovative imaging and innovative treatments. But we're tending to plateau at the moment, and we need to raise the awareness that bit more to make sure that those big grants come in for the earlier diagnosis and to reduce morbidity as well as mortality. I guess that's where we are with this. But I want all of you now just to think of perhaps one thing you would ask your political masters or the masters who control the budgets, what it would be you'd want them to concentrate on. And as you've just talked to Christopher, I'll come to you last if you don't mind. But Jayne, what's the one message you'd like to give?
So I think it's about embedding research and uptake of innovation in clinical care. And if we can ask DHSC and NHSC for one thing, it's to ensure the infrastructure's there and that there's the support for rapid uptake and delivery of new treatments and care.
That was sort of 1.5. I'll give you that. Okay.
Well, I did have, in that case, I had about 9 things I wanted.
Okay, Mark.
I would plead for a speeding up of the approvals process for interventions that either have sufficient evidence or are so overwhelmingly beneficial that they should be given a rapid access.
Thank you. And finally, Christopher.
I would advocate for evidence-based solutions powered by the excellent data that's already collected within the UK.
Well, thank you all very much. Firstly, it was incredibly informative for me, so I hope it is for our audience as well. We may have to do a couple of other things in the edit of this, but thank you all and have a good afternoon.